Regarding the type of knees available, with respect to constraint, number one is cruciate retaining. Number two is posterior stabilize. Number three is having a high tibial post, which gives a varus and valgus stability. Then is a hinge prosthesis or CCK. So 4 levels of constraints. Before that, you can have a unicondylar knee as well. Another way around, based on conformity of the insert. Deeply congruent joint, deep PE cuts, and a flat geometry design to improve femoral rollback and optimize knee flexion. And third is highly congruent knee. Number 3, based on mobility of the insert, fixed bearing insert and mobile bearing insert. A mobile bearing insert is a dual surface articulation, maximum conformity of tibial and femoral components, reduce polyethylene delamination wear and failure, reduce implant bone interface stress, self-adjusting to overcome slide component malpositioning. Then is a rotating platform knee, which might compensate for malrotation between tibia and femur and reduces patellofemoral maltracking. Disadvantages: high contact stress and backside wear. Poly spin out if flexion gap is too loose. Bristol study, RCT, no significant difference in patient-related outcome measures between mobile and fixed bearing years knee in 2 years. Another type of concept is femoral designs, which can be a single radius design, multi-radius design, medial pivot design. A single radius design is a knee flex around single radius, transepicondylar axis, maintain posterior condylar offset, maintain collateral ligament isometricity, reduce joint reaction force, allow conformity. A multi-radius design is a J-shaped radius of the curvature in sagittal plane. Femoral component has larger radius distally to distribute load over large area and more curved posterior to improve rollback, risk of mid-flexion instability, and reduce knee flexion from posterior impingement. Statistically, no difference between the two survivorships.